Good morning or good afternoon, depending on where are you as far as time zone is concerned, listening to this presentation. My name is Adam Torbicki. I'm from Poland, from a department which is a referral center for treatment and diagnosis of pulmonary hypertension. And my task today is to talk to you about access to pulmonary hypertension treatment in my geographic area. If you look at Eastern Europe, in fact, you see that even if you assess the density of European reference network centers, which are dedicated by European community to take care of the most complex cases in pulmonary hypertension, you see that eastern part of Europe and also southern part of Europe is grossly underrepresented. Here it is mostly due to our past, because many of our countries were under the specific economic system imposed by Soviet Union, and it changed only around 1990 when political opening of Eastern Europe led also to changes in economics, so that we could be more effective and efficient in using modern medicine for the benefit of our patients. But I think this type of problems, economic problems, may be different, but still affecting the healthcare systems in many areas of the world. So maybe our examples and our tricks how to manage this situation and how to catch up as soon as possible with the rest of the Western world could be useful for your centers, for your countries. I understand that I'm talking mostly to patients and patients' representatives, but I think this may be interesting for you to have this problem showed to you by a representative of medical community, so that you can see where we overlap, where we do something completely different, but everybody does it for the sake and benefit of our patients with pulmonary hypertension. So as you can see here, east from my center, which is here, we have only two centers in Lithuania, and those are in fact not full members of the European Reference Network Lung Pulmonary Hypertension, but affiliated partners. So this is slightly different position of such a center. I'll explain it to you slightly later, but it shows that this part of Europe, Eastern and Southern Europe, is not in fact integrated in the discussion of difficult cases which is ongoing between those referral centers, which you can see here, mostly placed in the Western world. This can be seen also when you superimpose those centers on the map of European Union. Those are these blue marked countries. And you can see that even in those countries such as Romania or Bulgaria, Slovakia or Hungary, we do not have full membership of centers which should take care of the most complex cases with pulmonary hypertension. We have here, on the contrary, some support from Pulmonary Hypertension Association, so thank you very much for being active and bringing to this community of expert centers your problems and your ideas. Very recently, we had such a discussion within European Reference Network with the group which represents Patients Advocacy Group, and we were analyzing the situation in the Eastern and Southern European countries. This time, it was dedicated mostly to access of diagnostic and therapeutic methods to deal with chronic thromboembolic pulmonary hypertension in southeastern Europe. Now, this problem is particularly important because, as you know, CTEPH is this area of pulmonary hypertension where very dangerous disease and progressive disease can be fully controlled or even almost cured by modern therapy. So this discussion also brings us a little bit to the causes of this not very good representation of Eastern countries in the European Reference Network. We were in the group of several countries: Poland, Romania, Czech Republic, Hungary, Serbia, Bulgaria, Croatia, and Slovenia. And please note that among those countries, only two which in fact had centers with full membership in European Reference Network were large countries. Others, Hungary, Serbia, all were below 10 million inhabitants, and Romania, in fact, a larger country and also a European community member, was in a little, in a sense, divided, because there were several centers which claimed that they are referral centers for CTEPH. Now, this is important because to get a full membership in European Reference Network, you need to fulfill some criteria. Those are, of course, criteria which are mostly related to methods which you have available for diagnosis and for interventions and for treatment, but also you are required to have an experience, and this experience is defined as diagnosing at least 50 patients, new patients with pulmonary hypertension, either arterial or chronic thromboembolic pulmonary hypertension per year. And if you look at the numbers of annually diagnosed patients with these diseases in full membership centers, you see that indeed, even in this period of pandemics, there were many more than 50 patients diagnosed per year. Whereas those centers which were not able to fulfill this criteria had much lower number of such patients, and those centers are not full members, but they can be included in this European community of centers discussing between themselves on difficult cases and supporting themselves within this group. Those centers are defined as affiliated partners, but you can see how big is the difference in their experience. Altogether, however, all those centers, now we have slightly more than 20, including also affiliated partners, they provide each year a number of patients around 2,000. So really the experience of this large community of centers and experts which are working there is enormous. I'm leading to the conclusion that it would be very good to have more representatives, more centers, even as affiliated partners, not necessarily as full membership, to share this information about patients, to advise or get advice from other centers. But how to do it, we'll try to talk about it later. Now, of course, this what I said was just related to number of patients and experience which is brought by this contact with many patients suffering from pulmonary hypertension. But those centers which are in the east and south of Europe, which are not big, they also had some problems and have some problems, at least with CTEPH, Here we have more information than in pulmonary arterial hypertension. They have less options to offer in terms of treatment. You see here in the on the right-hand side that most of those centers do not have access to pulmonary endarterectomy in their countries. They have to refer their patients abroad. This is the same, but maybe slightly less marked with another very effective method of treatment of CTEV, which is balloon pulmonary angioplasty. You see also that there are several countries that send those patients abroad. Now, you can probably accept this situation in small countries having not possibility to develop a high volume center for pulmonary endarterectomy, but it would be difficult to send abroad patients for treatment with drugs, with pharmacological treatment. So this is a problem, and to try to show how we in Poland attempted to improve the situation of patients, I'll take you for a while and present something that can be called Case Poland. Because we started from the very beginning, and in 1998 we really had almost nothing, and after this 22 years we now have really quite broad experience and quite ample armamentarium to treat various types of pulmonary hypertension. But this was a long journey, and many of my white hair, or silver hair as you call it probably in English, comes from problems that we had to resolve, and the way we did it may be useful for other centers which are on various stages of this journey. Some are at the very beginning, not having much resources and not having much options. Some are closer to optimal situation, but maybe it would be interesting for you to see how we went through this long and bulky road. So let's start from the very beginning. In 1996, epoprostenol was approved in the United States for treatment. It was so expensive that the company that considered at the time to make a registration in Poland, at the time there were no general registrations but just national registrations, stopped at the middle of the way because they thought that nobody will be able to buy this drug in Poland, either individually or through healthcare service reimbursement. At that time, a monthly therapy with epoprostenol was in Poland equivalent to a luxury car. So it was really out of question. However, we were lucky because we were invited to join one of the randomized controlled trials, which in this period started to appear. This was a trial with treprostinil, and this option was so interesting for us and for our patients that we were one of the globally highest enrollers. I think we enrolled something like 17 patients to this trial. It was a positive trial, and the only thing that we were anxious about was whether, when the double-blind period will end, whether we'll be able to get this extremely expensive for us drug to our patients without paying for it, because we would not be able to do it. And at that time, Martin Rothblatt, a great personality in pulmonary hypertension treatment, at that time she was the chairman of United Therapeutics, which produced this drug, promised us to us that they will continue to provide free remodeling to the Polish clinical trial patients until it becomes approved and reimbursed in Poland. And this was extremely important because other companies also followed this pattern. And in the next years, we were able to enroll many patients to offer them drugs. Most of them turned out to be effective: treprostinil, iloprost, bosentan, and brisentan. Some not, beraprost or sitasentan. But anyway, this was a possibility to give something to our patients. And the companies followed to provide the drugs after a double-blinded phase was finished, even if the country couldn't afford to pay for it. But of course, you have still sildenafil, of course. And again, we were, in most of those trials, we were one of top global enrollers because this was the only way to give to our patients some potentially active drug. So in sildenafil also, we were, I think, second globally enrolling center. After this, however, the period of many new randomized controlled trials was beginning to end, and we managed to convince the Ministry of Health that patients that are now diagnosed but cannot have access to randomized controlled trial drugs need to get something. And we were able to convince them that on individual applications, if we can document well the diagnosis of patients as one suffering from pulmonary arterial hypertension, we can apply for 3 months of treatment. After 3 months, we have to reapply for another 3 months without knowing whether we'll get this approval. So this was a risky business and very time consuming. We had to fill many documents because those drugs were expensive, but this was how it worked for quite a while. And we decided that it cannot be like this, and it was really very difficult to do it. Why? Because there were several problems. First of all, we were dealing with rare disease, and at that time, at least in our country, and I think in many countries, rare diseases were not considered very important. They were not understood. There were not too many patients. The pressure from those patients, still not grouped in association, was not very strong. Money was relatively important per person. The effects were not easily documented because, as you know, almost none of these trials had mortality as an endpoint. So the discussion with those that decided to give reimbursement to this particular therapies was not very easy. What's more, I don't know how in other countries, but in Poland, many people were changing within National Health Fund, within the Ministry of Health, within a special agency, something like Polish NICE. And when we convince somebody, usually after a couple of months, he or she disappeared, and we had to return to speak to other people and to convince them in turn. But anyway, we were doing it and tried to use also the pressure of the industry. At that time, as I said, patients' associations, at least in Poland and in many Eastern European countries, were still not very well developed. And also some of those patients died early because therapy was not as effective as it is today. And of course, as I already said, the costs of drugs per person was quite high. So what we did, we decided to set up a strategy and kind of campaign to change the situation and not to apply for each and every patient for a single drug for 3 months, but get a kind of program which would be working swiftly and without necessity of filling too much papers, with the hope but not certainty that we'll get the drugs. So we wanted to show to our dissidents, to those that decided whether they will give money or not, good example from other countries. We also decided to count as precisely as possible our population which is in need of targeted therapy each year, and so the cost could be calculated, because otherwise it was supposed that they are enormous. But we had, of course, an issue of number of incidental pulmonary hypertension, which is relatively low. So we wanted to calculate these numbers very precisely and pick a momentum, or even create a momentum, to show this to our Ministry of Health and to our National Health Fund. And this momentum was created by us in June 2006. We organized a large symposium, Congress, Pulmonary Circulation European Forum, where we invited more than 40 eminent speakers from all over the world. You see here Nazareno Gallier, you see here on the right-hand side Mark Humbert, and many other people to speak to us and to discuss themselves and to present all this to our leaders and members of Ministry of Health, but also to play a very special card. We were in the position to show that the first person that applied prostacyclin intravenously in men was our Polish doctor, Professor Andrzej Szczeklik, and that he gave it to his friend, pharmacologist, Professor Gryglewski. And we organized a session where they were reporting how it happened and what happened, what were the consequences. And this was largely unknown to the whole medical community, including those that first treated pulmonary hypertension with prostacyclin, such as Professor Rubin, who was chairing this session together with Professor Gryglewski. So our leaders were faced with a situation that two Poles were absolute pioneers in clinical administration of prostacyclin, yet after many years we were still not able to give this prostacyclin to our patients. So this was a very nice trick to play. There was, of course, a lot of discussions between those people that didn't know each other, but had very important role in applying prostacyclin in human beings, also for pulmonary hypertension. The next thing that we did was we invited our friends from several countries, and here you see the flags of those countries, which included Mexico, Australia, Spain, and also Czech Republic, to say and to present to all of us how they managed to organize their system of treatment of pulmonary arterial hypertension. So we have heard about Australia, but this was difficult to compare to Poland because the healthcare budget, national health budget per year was 5 times higher in Australia than in Poland. So they had better situation, but this was nothing strange. But the card we wanted to play was to show that our neighbors, Czech Republic, with a population of 10 million, so 3 times lower than Poland, and a very similar national health budget of 690, whereas in Poland we were slightly less rich and had 400 euro per citizen per year, they can offer to their patients quite a list of pulmonary arterial hypertension drugs. And so when our leaders, political leaders and financial leaders, heard that Czech Republic can do it, And when we showed to them that about 200 patients only should receive this treatment just at that moment in Poland, because we calculated from data which we collected from our centers that had some experience with those type of patients, and they diagnosed these patients and could refer to us the numbers. We received finally in 2008 an approval to start our treatment in a more organized way. At the beginning, we had two drugs, sildenafil to give orally because it was the cheapest one, and iloprost to give as an inhalation because it was a prostanoid. Then we also got, after this first line treatment, we got also bosentan for patients with congenital heart disease and pulmonary arterial hypertension. Then, because we needed combination therapy, we traded one inhalation of iloprost from 9 to 8, because anyway, usually patients slept during night and didn't inhale this ninth inhalation. And the cost of this one single inhalation was the same as adding sildenafil to iloprost. So very early we had the first combination therapy. Then we also got approval for treprostinil subcutaneously, and this was a major achievement, and so on and so forth. And we started to gain ground. A very interesting and important thing is that first year of this therapeutic program, we performed an analysis of survival. We showed the mortality rate over the first 24 months after initiation of the program, and we compared it to the data from France. You see here 5 years of France with this blue line showing naive patients before 1992, when there was no drug which could be used for pulmonary arterial hypertension. And here 2 lines which were much better in terms of survival. And our patients, their survival at 2 years after the beginning of the program was quite similar to this new modern Kaplan-Meier curve of survival in pulmonary arterial hypertension. Another thing that we did was that we compared the data, survival data in patients who started as a therapeutic program to historical controls. And even here, though the numbers were not very big, you can see that those that had opportunity to start right after diagnosis were doing better when compared to those patients who, some of them even got the drug, but this was the drug which was given to him or her in the frame of randomized controlled trial. So sometimes they had to wait quite long for a new randomized controlled trial to open, and moreover, during the first 3 or 4 months, some of them were receiving placebo. So even in this aspect, we could document that the money that we are getting for the therapeutic program were not wasted. Of course, on each step of our journey, we had some problems which we identified, and we tried to find a way to resolve it. For example, in this particular moment, we were not supposed to include class 2 functional class 2 patients, because there were still not convincing data. Then the situation changed. We were not able to give drugs to portopulmonary hypertension and to HIV because the number of patients in the trials were low. So we had to fight for it. We didn't have any option for pulmonary veno-occlusive disease, and nothing for kids, and nothing for pregnancy, because drug labeling was so badly constructed that the government was not very much willing to pay for those drugs because they were not approved formally. They were never tested in pregnancy. So each of those steps on our way, in some way, we tried to eliminate. And I must say that this was a great challenge, but also great satisfaction now to have already triple oral combination therapy and the prostanoids. And then I was not able, because of time, to discuss the issue of interventions, septostomy, also interventions in chronic thromboembolic pulmonary hypertension, lung transplantation, which is still not very successfully introduced in Poland. The waiting list is rather long, but we have now 2 very active lung transplantation centers, and I think the situation will also improve. Now, of course, this information and this journey I presented to you from the position of the physician in charge. I was the head of the department most of this time when the whole battle for treatment was ongoing. But now the situation for countries and centers which are now in some stage of this journey. As I said, some will be here at the very beginning, some will be in the middle, some will be later. It's much better because they have also useful partners, which we didn't have. First of all, from the point of view of patients, such centers can be supported by patients groups such as pulmonary patients advocacy group within European reference network, very interesting group which is closely collaborating with the best experts in the field in Europe. We have 2 programs from Pulmonary Vascular Research Institute. One is dedicated to improve access to care globally. This is extremely interesting because we are there. I have the honor also to take part in this initiative. We want to see what we can achieve almost with nothing, just by organizational changes and using maybe generic drugs which can be organized from some of the companies for developing countries which really do not have much to pay for treatment of these rare diseases. So minimum diagnostic requirements, minimal therapeutic possibilities to save those that need most this type of treatment. And there is also a similar group in PVRI led by Professor Joanna Pepke from Cambridge on patient empowerment, and we are collaborating. These 2 groups just a couple of days ago had a common joint meeting, and we were discussing how to help the patient to be in a stronger position and with the greater chance to get the adequate treatment. There is also an initiative to assess the access to the most advanced care among European Respiratory Society. It is called PHAROS, and we are trying to map Europe in terms of who should get what and where in order to have this map of possibilities, high-tech possibilities and high level of experience possibilities. Of course, those useful partners are also pharma company because they always want to provide the drugs and are able also to give some compromises to start the whole strategy of treatment in this or that country. Payers, this is of course something that you had to convince, as well as to convince health policy creators. We always were waiting for somebody from these 2 groups to have in their family, not wishing them bad, but to have somebody in their family, distant family, who is suffering from some form of pulmonary hypertension, to understand the needs of this patient's population. However, nothing can be done now, especially without the strong and very effective Pulmonary Hypertension Association, and also with without the collaboration with the media. But here, Pulmonary Hypertension Association has a very good links. There are also many other options, but this is up to you to try to find a way to them and use their power and influence and experience to get as much as possible possibilities to treat yourselves, your families, your loved ones, and all the people with pulmonary arterial and chronic thromboembolic pulmonary hypertension whose fate can be improved by medicine. Thank you very much for your attention.
So thank you once again to agreeing to answer all the questions that our members sent to your presentation. So I think we'll just get started. And your presentation, of course, was access to PH treatment, challenges and answers in Eastern Europe. And this was a very interesting presentation to very many of our members, and also it's an important presentation as we have many members in Eastern Europe. First question from me, you showed that one of the criteria to become a full member of ERN Lung was number of PAH and CTEPH cases. Will this not exclude smaller countries from ever getting full membership, since they never will experience that many patients? For instance, like in Norway, where I live, where we only have a population of 5.5 million. But we have good healthcare system, but we don't have that many cases.
Yeah, I think it's a very relevant issue and question. I think we can discuss it with the new chair of ERN Lung, Professor Humbert, who is in fact involved in pulmonary hypertension most of the time. So he understands this issue. The original idea was to have centers that have truly large experience, and this you can gain only by the number of cases. But I think that even if this is not this suggestion is not followed, I think that there is a very good way of entering ERN Lung as an associated partner or affiliated partner, because in fact it does not eliminate any of the possibilities to exchange experience, to consult patients. The only thing that you don't get is voting rights, and voting rights is not that important in supporting patients and improving care. So of course it's nice to be a full member, but if you are an affiliated partner, and here you don't need to have to meet this criteria, you are on the good way to interact with all other full member centers.
Okay. Your sound is a little low. Could you take the microphone a little closer to your mouth, maybe?
Yeah. I'll try. So you don't hear me very well, yes? It's better now?
Much better, yeah. Thank you.
All right.
In Poland, this whole journey to reimbursement of medication seemed to start with participation in trials. What is the best way to convince pharma companies to include your country in trials when your country does not have the same good healthcare infrastructure as large Western countries?
Yes, this is probably a problem. When we started in Poland, it was a completely different story, because most of those drugs were still not approved for use in pulmonary hypertension.
now they are used. And the most important thing is probably to attract attention of the companies and show that in your center you can perform the key evaluation in a good and standardized way. And those things are right heart catheterization, 6-minute walk test. So this is really important to have good right heart cath laboratory, because by this you make a final diagnosis. So I think usually you have representatives of various large companies that are running trials. And if you are able to get in touch with them and say that you are interested, they are also looking for centers to participate in trials, because the very important thing in a trial is to have very quick enrollment, because you concentrate your investment in a shorter period of time. So they are looking for good centers. If you are a good center in terms that you are a reliable diagnoser and a partner, you have a big chance to start. Having said that, I must warn you that most of the trials now are in their protocol. It is in fact the tested drug or tested compound is an add-on therapy. There is very little possibility to have naive patients enrolled in the trial, because it seems not correct in terms of ethics. So you need at least to have generic drugs which you use in your patients. And by generics, I think that bosentan and sildenafil are the most likely. And if you have it, you are in a way in a good position to start participation in trials, and this is of course important.
Yeah, no, I think most countries have sildenafil and bosentan, so I think they fulfill this requirement. And also, I think going to Eastern Europe would be attractive to pharma companies, because their people are very eager to join the trials. And in this way, they can fill up the available places very quickly. But don't you think also it requires a good, reliable PH doctor that they can work together with, like yourself?
Yeah, I think that of course this is a good idea to have something like this. Yes.
Yeah. Question from Bulgaria. Do you think that the criteria to join ERN networks should be tailored to the population in relation to the number of patients with rare lung diseases? I guess
Yeah, this is more or less what you asked me, and we've already managed to reply to this issue. This is of course correct. And the answer also, if you cannot reach the thresholds, try to apply as an affiliated partner.
Yeah. Why is access to IV therapies for PAH in Eastern Europe so difficult, due to lack of policy decisions or high prices of these drugs?
In my opinion, it is mostly due to high prices of these drugs. And please consider two issues. First of all is the price of a standard therapeutic application, but different from oral drugs, which have a clear-cut dosage in most cases. IV or subcutaneous prostacyclins can be up-titrated almost without any limits, and so the price per patient cannot be evaluated beforehand. So always those that pay for those treatments, reimburse such treatments, are somewhat unhappy without knowing the final sum of money that they need to provide by each month, by each year, because of this differences in dosage per individual patients. And those differences are quite high. And they are not really the same in different centers. Because, for example, if you look on epoprostenol and the dosage of epoprostenol, if you look at French center, one of the most important centers in the world, they do not exceed dosage like 30 nanograms per kilo per minute. While, for example, in Japan, they go up to 100. And the same is true for treprostinil. In Austria, they use very high dosages. In other countries, much, much lower. And this makes all the difference related to budget, which must be assigned to this. So I think the price, but also impossibility to predict exactly how much drug you will use per year per patient.
In what to what extent, according to your to your view, can countries manage to negotiate the price? Can you manage to negotiate and get a better price because you are in a low-cost country, or?
Not too much, because this is one of the issues of one of the next questions. But if you the usual answer that you get from a company is that they cannot go down with the price because this will motivate people to smuggle the drug across borders. And this is a real problem. So this is at least how they explain the inability to adjust the price to the possibility of a country budget. I don't know whether it is true, but in some occasions, I know that some of the drugs not related with PAH were in fact exported illegally to other countries. This was the case, for example, with low molecular weight heparins in Poland. In some moments, we were not able to buy it for our patients because everything went abroad, because it was relatively low priced in Poland. So this may be a problem.
What kind of methods do you use to diagnose PVOD? Or do you recommend lung transplantation to patients in an advanced stage?
Yeah, PVOD is really a challenge, diagnostic challenge. Some time ago, it was even said that in most cases you learn about it at autopsy or studying explanted lungs. But again, the French colleagues made a lot of contributions to teach us how to diagnose it relatively early. The most important thing is to look closely on your CT, and especially high resolution CT. It gives a lot of information, and there are some changes, mostly ground glass opacities within the lung, and signs of congestion, which you can find in patients that have normal pulmonary wedge pressure, so they do not have post-capillary hypertension induced by left heart disease, but it is induced by veins which are still within the lung parenchyma. So high-resolution CT is the mainstay of diagnosis. Also, you have to look at the gas transfer. It is very, very low in PVOD, even in cases which still did not develop very high pulmonary hypertension at your right heart catheterization. Finally, in young patients, and we recently had an example of this, when you are not sure, because clinical presentation and also higher resolution CT may not be fully clear cut to diagnose PVOD, you can also try to check for genetics and mutation of EIF2AK4 gene, because in young patients, this is the most common cause of PVOD. We had one such a patient still in times when we couldn't identify this mutation in Poland, and we contacted again our friends in the ERN lung PAH network. Again, it was the French center, and they confirmed that if we can find this mutation, this will solve the diagnostic problem. And they also invited us to send the samples, and they did it for free. And in fact, this patient was very early transplanted, and he's living an excellent life now and looking forward to have a kid. So in this case, this ERN lung network was very useful and friendly, and it solved our diagnostic problem. Now we can do this type of genetic studies already in Poland, but if you do not have it in your centers, please try to contact French colleagues. They are very, very supportive in this area.
A question from Slovakia. Do you have a recommendation on how to ensure better organ donor collection? This is quite the challenge in Slovakia.
Yeah, I think that this is also a problem in Poland, and I'm not sure whether I am aware of current system that works there. But if I would have a contact to this person who asked this question, I think that I could help by contacting him or her with our most active center in Gdańsk, and they can certainly provide support in terms of advice and presentation of our strategies.
Okay, great. I know this has also been a discussion in Norway, and I think Spain has done quite well in this area.
Yeah.
And I know doctors have gone down to Spain to learn. And one of the things they talked about was that the conversation they had with the carers of a person who is deceased is very important, that you have a very good conversation and approach this person in a correct way. So maybe some of the answer is there.
Yeah, Spain is a very good example, and also it was organized in Spain in such a good way, despite the fact that it is a strongly Catholic country. So there are some religion issues, yet they managed to solve this problem. And also for us in Poland, this would be a good example. You're right.
Yeah. Finland, are many left without complete right treatment?
Not in Poland, because I can speak only for Poland. I think, unfortunately, in many Eastern European and Southern European countries, this might be the case. In Poland, we are now in the situation that we can offer treatment to any patient with pulmonary arterial hypertension or chronic thromboembolic pulmonary hypertension. There is one issue. If you ask about complete treatment, I must say that we have some problems with initiating already from the start a double oral therapy. We are forced to start with monotherapy, but we use a trick, because we usually convince patients to buy for themselves generic sildenafil, which is very cheap in Poland, and we offer them bosentan. So at the very beginning, they are already supported with double oral therapy. And then after 3 months, we recheck such a patient. And usually at that time, we switch self-supported sildenafil to reimbursed therapy within the program. The same is true also for patients that require, in our opinion, from the very start, also parenteral prostacyclin. because they are at high risk, but they are still in third functional class. And in Poland, you have to be in fourth functional class to be eligible for starting the therapy with IV prostacyclin. So this is a problem, but we somehow try to overcome it, because this is extremely important to start very strong therapy in young patients with high risk. And as you know, the risk scores now are not only related to functional class, but there are several other things, especially in hemodynamics, which you take into consideration. So even if a patient still can walk and is not, he or she is not in fourth functional class, he still or she can be at high risk. And we try to convince our payers to change those standards, but so far they are quite resistant, but still we usually start as soon as possible. I cannot tell you the details because it might be somewhat dangerous for me.
Okay.
But we don't leave those patients without early and strong therapy, including IV prostanoids, also because there are data, especially from France, again, that it is highly effective.
Yes. I like this idea about the generics sildenafil. I know from some countries that they are the patients are a little skeptical when it's generic. Do you think that the generic variant is always as good as the original, or?
Well, I cannot say it for sure, but all the medicine goes in this direction. And in most cases, generics are as effective as the original drugs. So I would not care. Of course, you can look for generics which are maybe delivered by well-established companies. I don't want to make here any to give any names, but there are companies which are on the market for 20, 30 years. They live from generics, and they have a very good quality of products.
Another question from Finland. Did I understand right that many Eastern Europe land has not PH treatment hospital, only patient organizations?
Oh, maybe I did not make myself very clear when I was talking about it. No, this is only the issue that some of these PH centers were not included in ERN network, neither as full members or affiliated partners, despite they have some experience and they treat patients with PH. Yet there are some representatives of patients' organization within the group supporting ERN from the patient side. So no, it's not that they are only patients and no hospitals, but the hospitals are not represented from certain countries. Still, there are patients representatives which are there. So this is a good situation because they can make this access of a hospital easier. They know more about ERN, they more know about the criteria, how to enter either as full member or more likely as an affiliated partner.
Yeah, and this is of course also the case in Norway, where I live, that they are, for some reason, they are not affiliated member of ERN, but still there are definitely PH hospitals.
That's strange because Norway has a very good healthcare system, and also I know Professor Andreasen from Oslo, who has a very good service for chronic thromboembolic pulmonary hypertension. So try to motivate him to apply.
Yeah, I should, because he is my doctor, Arne Andreasen, in Oslo. And I see him often, and I have a good relationship to him. And when ERN was started, I wrote to him and pointed out this, but he never responded to me. But I will definitely tell him next time I see him.
Send him my best regards, and maybe this will also help. But we wait for Norway in the ERN lung PAH.
So you know each other?
Yeah. In fact, when we started our balloon pulmonary angioplasty program, we sent our interventional radiologist to his center because he was the first in Europe to start this program. And our colleague, Professor Pietura, went there to attend two interventions, and this is how our center started. Then we changed a little bit the methodology and moved slightly more to Japanese way of performing BPA. But the whole story started with collaboration of our center with Dr. Andreasen Center. So my best regards and thanks to him for this.
Okay.
It was in 2013, so almost 10 years ago.
Yeah. Another question from Finland. Is it harder to get treatment therapy to CTEP than idiopathic PAH?
It's a good question. I'm not sure. The problem is pulmonary arterial hypertension treatment is mostly money. The problem is chronic thromboembolic pulmonary hypertension is mostly surgery and intervention. Surgery is very difficult. And to be good in pulmonary endarterectomy, you really need a lot of patience. And the learning curve is relatively long, and you really need experience, either by going to one of the high volume centers and learn, or learn in your center with the help of somebody coming from a high volume center. So in some countries, people are being sent for this type of surgery abroad to centers in Vienna. I am now talking about Eastern and Southern Europe. Vienna is performing some of these interventions. Prague is performing some of these interventions for other countries. We are also able to do it. We have a very good CTEF service. So if you don't have it at in your country, and this may be due not only to lack of good surgeons, but to lack of their experience, because you need really to perform a lot of these operations to do it right. And this is not only surgeon, but the whole team of anesthesiologists, and then post-operative care here is very special, different from other cardiac surgical interventions. So in some countries, probably such a PE center for surgery in CTEF will never be developed, and it is reasonable. But you need to have access, and easy access, to such a center abroad. Well, and balloon pulmonary angioplasty is probably easier to implement, and it also may help about 30, 40, even 50% of patients with CTEF, but also you need to learn somewhere, and so the collaboration at the very beginning is important. Also, these are not cheap procedures, but for example, CTPH surgery you perform only once, and then it's okay. BPA you have to perform several times, and this is much more difficult to be successful without performing at least 5, 6 interventions. But those interventions are similarly priced as coronary interventions. So this is not very expensive, yet it is more expensive than coronary angioplasty because you need more sessions per patient to cure him.
Yeah, I know that in Norway they have discussed if they should maybe join forces on a Scandinavian level and have all the operations being performed in Aarhus in Denmark, because then they would get up the volume, because there is so little volume in Norway, for instance. So maybe this is
This
also
is a
the
very
case
good
in-
strategy. Yeah, this is a good strategy.
Spain, based on your experience and data in Eastern Europe, my question is this. I understand that with the cold in Eastern countries, blood pressure can rise more than in other countries with a warmer climate. Does this affect the pulmonary arterioles? Is the medication and treatment for pulmonary hypertension disease the same, or does it increase in dose?
Well, I think Eastern countries are not colder than Western countries. So I think that how you are in a situation where you are in a colder country than Spain, of course, but I'm not aware about any differences in terms of pulmonary circulation. We have the pulmonary circulation is hidden deep in our bodies, so the body temperature is probably the same. Though, of course, we invite our Spanish colleagues and Spanish patients that they live in such a beautiful climate, Mediterranean climate, which is so nice and also healthy. But no, I don't think that you need to adjust the dosages to climate. Also, because we are living most of the time inside, and I'm afraid that in Spain, in highly you have this air conditioner systems. Sometimes you get much more cold than we have here without air conditioning and normal temperatures outside.
I guess one thing for sure, if you live down south in Europe, you probably get more vitamin D through the sun. And I've heard that some people talk about vitamin D being dilating the blood vessels and maybe positive for a PH patient. Do you know anything about vitamin D and PH?
Not really.
No.
Not really. Well, the truth is that you shouldn't have too much vasodilation on the systemic side, because if you drop your blood pressure, then your perfusion of the coronaries, including coronary going to right ventricle, it may be less effective, and this would not be good. But I don't think it has a large influence on the clinical course of the disease.
No. Oh, a long question from Hungary. Our patients get some medication only for 3 months based on an individual application. And as you have mentioned, it is a lot of paperwork and we can never be sure that it will be approved. It is a lot of stress for patients that is dangerous in their condition. We believe it can decrease the effectiveness of the treatment. Other studies that support that it is not beneficial for patients. Maybe buying medicine in bigger volumes would get us more favorable prices. Is there any help that the network centers can give to those outside the network to support our argument?
Well, first of all, of course, stress is not good for anyone, and patients with pulmonary hypertension usually have already increased adrenergic drive. They have some tachycardia. This can be maybe not deleterious, but it's certainly not good for their well-being. Whether how to get rid of it? Well, not try to make this argument. I don't know about any trials that would definitely prove this, but it's common sense that tells you that you should keep your patients, especially with this type of diseases which affect cardiovascular and respiratory system, away from stress, especially if it is not obligatory, not intrinsic to the disease, but is generated by logistic problems. Whether buying medicine in bigger volumes could get more favorable prices, I think if a hospital is doing it, probably they get a discount. I cannot say anything for the network because each country has its own strategies, and and prices, which may differ a little bit, and also the vendors may have slightly different strategies. Certainly, big volumes reduce prices. So this, I think, can be, of course, utilized to reduce the cost of treatment.
I talked to a friend of mine who was also a PH patient, and when he had a right heart cath once, he said that when everything was ready, the doctor was just talking to him about everyday life issues, and he was wondering when was he going to start and perform his procedure and investigation. And then when he talked to the doctor afterwards and he pointed out this, the doctor said, I just wanted you to get to stress down and get you in a ready state before I started measuring the pressures. So if you are stressed, then your pressures also go up?
Yes, because of the tachycardia and additional signal to the right heart. So, of course, if you are stressed, the heart, the cardiac output increases unnecessarily because you don't need it. You are not running, you are not going up the stairs, yet your cardiac output increases. If your cardiac output increases and the vessels in the lung are narrowed, you'll get higher pressure also in pulmonary arteries, also in systemic arteries, of course. Even in healthy people. But this doctor was a good doctor, because you should do exactly as he did, not to be hurry because you already have another patient in the cath lab to catheterize, but stabilize the patient, talk to him. He might be stressed after the puncture, which he was afraid of. So this was a very good doctor.
Yeah, the doctor was Dr. Grünich in Heidelberg.
Yeah.
Question from Croatia. I have no question, just a big thank you for the wonderful presentation and the extraordinary effort that you put in over the years to be at the level you are today. This is an example of how you should never lose sight of a goal, and no matter how difficult and complicated it is, you should continue on your way, step by step. Thank you.
Thank you very much for those words. Indeed, I have some silver hair due to the stress, which was a common issue down on this road. I'm happy to see that it comes from Croatia, because I love Croatia so much. It's such a beautiful country and nice people. And I'm longing to be again in Croatia and maybe have some sailing experience on your lovely coast. So thank you.
I have to say also, when I mentioned that you would talk to us, I talked to a Polish person, and she spoke very, very highly of you, and she simply said, you're the best. So,
well, I don't claim this. This is not important. Good is enough. Best is too much.
But I think she meant in all respect, by the way you have helped the patients in Poland. The question from Slovenia. First of all, congratulations for the achievement, and thank you for all the efforts. I wonder if it would not make more sense to take the relative number as a criteria for the number of newly diagnosed, since, for instance, according to the population, Slovenia does not have 50 new patients a year. I guess this comes back again to what we talked about.
I don't know exactly the population of Slovenia, and of course you could calculate how many patients per year should be diagnosed there. Remember that this does not necessarily represent the number that is really diagnosed, because this is a question of awareness, and we know very well that this is an underdiagnosed disease. So, of course, but we've already discussed this issue, so I think we can move on.
But I guess when it comes to the number of patients, would you say that a number like 50, 55 patients per million is what you should expect in any country?
per million.
Because
No, it would be too high, I think. Yes, but probably within, if you count also CTEPH patients, this is probably something that you should take into account. Yeah.
yeah, because I think this is what they found in the Swedish registry, and I guess
Yeah.
Sweden are doing a good job diagnosing, and they are about 50 per million.
Yeah.
Question from Austria: would it need more support or understanding from the government, or an upgrade in legislation? Let's see, is this?
Yeah, I think, but it's a good that you showed the next question, because it refers also to this issue. So
Yeah.
I think you should first convince somebody from the government in order to change the legislation, because they need to be moving this forward. You will not alone change the legislation, but you can also use another approach. And if you show the next question, this will go, yeah. Would it help to involve and strengthen PHS? Yes, I think this is a critical issue. And the patients' association should not go to government. They should go to legislators directly, which is the parliament. And in fact, in Poland, we several times were present at the meetings of the Healthcare Commission of the Parliament, presenting problems related to pulmonary hypertension and the patients with rare disease. So PH associations are critical. And in fact, when we started in Poland in around 1998, then fighting for reimbursement, there were no PH associations. And even if somebody was starting, this was not really a big help. Now we have a very strong association, and I think in other countries it is also much better. So they should be involved.
Bosnia-Herzegovina, how to give patients individual approach where there are no PH centers?
I don't understand very well this question, so I cannot answer. Well, if there are no PH centers, of course you cannot take care of those patients up properly. But I am not sure I understand the idea of this question very well.
Yeah, no. In your opinion, having Poland example in mind, what to do when pressure on government institutions does not give results?
Well, I think here again, pulmonary hypertension associations and media. I already mentioned this issue of addressing parliament and parliamentary commissions, but you should also remember that politicians are always most afraid of their media image. So if you are able to get through with your message to the media, this is a very, very important thing. And an advice is to start with World Pulmonary Hypertension Day. There is such a day during the year when you can attract the attention of the media. And then this will have also, this should also affect the institutional people that make decisions about reimbursement, about supporting rare disease. Rare diseases have now a strong place in the healthcare strategy. So it is a very good moment to try to fight for your rights.
Belarus, how long does it take to get drugs for patients from the moment of diagnosis in Poland?
Well, immediately. If the patient is diagnosed today in our department, it gets drug in the afternoon. So this is not any delay is there.
Can pharmaceutical companies make concessions to countries where drugs are registered for a long time and not registered at all because of high costs? Allow the release of generic before the patent of the original drug expires. Of course, this would be decided for each country separately, but it can increase the availability of drugs for patients and be cheaper for the national budget. Was such a strategy discussed?
Well, we've already talked about it. The issue is that if you are in a country which has easy transfer of people and goods across borders, such a decision to lower the price is not possible, because this would result in illegitimate transfer of goods and smuggling, and this would be a black market. But for Belarus, which is relatively isolated, maybe there might be this type of things discussed with the companies. Please try. There is nothing wrong with it, and if you can get such a concession, this would be fine.
Spain, if there are no specific treatment for children in Poland, how can they be treated?
Well, this was at the beginning, this was an issue in Poland, but very quickly we made an argument that it is very difficult to get good randomized controlled trials showing strong clinical endpoints in children. They are usually not included in this trials, especially at the beginning when the drug has not shown that it is safe. So we managed to convince that there is a little difference between a 17-year-old guy and 18-year-old guy. And so slowly, first with those drugs that were longer on the market, for adults, we moved up to second year of age, and this was extrapolated to this population. I'm not sure, because I'm not a pediatric cardiologist, what is the current situation, but most of the drugs, at least the core armamentarium, which is available for adults, is also available for children, at least above second year of age.
The situation in Europe is very difficult. In your opinion, how could an association from Spain help improve the situation in Eastern Europe?
Just exchanging your experience and showing good examples of successful actions. For example, you can try to make a joint World Pulmonary Hypertension Day with somebody in Bulgaria, for example, and have this international linkage. This is so easy now with all the options that we have, and this will make this day very attractive. If I have the chance to communicate directly with Spain, it always brings me a smile on my face, because this is nice. And I think that also media would be interested to have this experience from your side, and to see well-treated Spanish patients expressing their good quality of life as an example. So I think it's a way to move.
Well, that was actually the last question. So thank you very much for both your presentations and answering all these questions. And thank you so much on the behalf of European PH patients. I would thank you for the excellent work you do and for them. Thank you.
Thanks a lot, and let's have peace in the world and in Europe as a final message, because we are trying to improve quality of life, and there are people that are not concerned with human life at all, and this should be a very strong message from the medical community and patients community. It is unacceptable that in 21st century people are trying to document their ideas by killing other people. It's absolutely unaccepted.
And of course, the people of Ukraine are paying a high price, but also it puts a lot of strain on, for instance, Poland, because now I know there are many refugees in your country, and maybe also PH patients.
And it's a very nice gesture. In fact, started by the two pulmonary hypertension associations, Ukrainian and Polish. And Polish government gave immediately all the rights of Polish patients to those patients from Ukraine that are moving to Poland to get help and rescue. So those people will be supported by reimbursed therapy, all kinds of therapy, when in Poland. Our problem is now what will happen with this newly introduced drugs when they will moving back to Ukraine. So we are in fact within PHAE group, which is taking care of access to therapy. We are trying to get help from pharmaceutical companies to support, after return of those patients to Ukraine, to support them with free drugs. We'll see how it works, but this is one of the ideas that we have to push forward, and I hope it will be a successful action. First of all, I hope the war will finish as soon as possible.
Yeah. And you know, the great welcome that you have shown in Poland is also something that we've seen in other European countries. And I know my wife, who is the president of one of the Ukrainian associations, she was in Krakow just a few days ago, and she helped other patients to fly to Italy and Spain and so on. And also there, the PH associations are taking care of these patients and help and greeting them with open arms. So this is a great show of solidarity across Europe, and in big contrast to what we see from some of the war pushers. Okay.